So today we will talk together about sexually transmitted infections and sexually transmitted diseases. So these two are the definitions that the US Department of Health and Human Services did about these two concepts. Sexually transmitted infections are defined as a pathogen that causes infection and that spread through sexual contacts. While the sexually transmitted diseases are recognizable diseases, so alteration of the normal health, that has developed from a state of infection. So first we have the infection, and then not in all cases of infections, but in a percentage of that cases, we have the diseases related to that infection. Of course, the diseases are different from pathogen to pathogen and from patient to patient. So that's the epidemiological review of the STDs, so the sexually transmitted diseases. Approximately each year we have about 20 million new diagnoses of sexually transmitted diseases, and almost half of them are among young people between the ages of 15 years to 24 years. We can see that we have a sort of balance between male and female incidence, but it changes between pathogen and disease and disease. What are the pathogens involved? We can divide the sexually transmitted infections and diseases by the clinical picture that they give. So we have the inflammation, so the infection of the urethra and the cervix, so urethritis and cervicitis, caused by Neisseria gonorrhoeae, Chlamydia trachomatis, or Mycoplasma genitalium. Then we have the presentation of the STIs as genital ulcerations. So we have the syphilis caused by the Treponema pallidum. We have the herpes, the genital herpes, so herpes simplex 2, but also the herpes simplex 1, the Haemophilus ducreyi, and again, Chlamydia trachomatis. And then we have the others, other sexually transmitted infections and diseases, such as the HIV infection that we talked about last time, the viral hepatitis, and the HPV, the human papillomavirus. So what are the problems nowadays about the sexually transmitted infections? First of all, they are a class of diseases that are spreading more and more each year. So we have a problem of increased incidence of all the STIs and STDs. That's because most of them, we have patients of young age, so we need to do a sort of educational program about sexually transmitted infections on the young population. Another big problem about the STIs is the antibiotics resistance. We will see later when we will talk about the treatment of the gonorrhea that the antibiotics resistance is a very actual problem that we need to keep in mind and to focus on in order to do an appropriate antibiotic therapy when we talk about the gonorrhea infection. So let's start with chlamydia. Chlamydia is the most common bacterial STI. We have an overall prevalence of 4.2% and in the female patients, and 2.7% in the male patients. So it's more frequent in female than in males. The incidence in this case is higher among adolescent girls aged from 15 to 19 years old. And then we have the next age class, but always young women aged 20 to 24 years. So in general, we can say that chlamydia has a higher incidence in females from 15 to 25 years old. while gonorrhea is the second most common bacterial STI. The global prevalence is lower than chlamydia, but it's very important. We have 0.8% among females and 0.6% among males. So in this case, we have a prevalence of female patients too, and the age goes from 15 years old to 49 years old. About Neisseria gonorrhea, we have to talk about the increased resistance to antibiotics that we have seen in the last decades, that have changed the guidelines, the general guidelines for the antibiotic treatment of this kind of disease. We will see later the actual guidelines. But most of all, when we have a case or just a patient that presents with a clinical picture that is comparable to gonorrheal infection, we need to think about the possible co-infection, which is very frequent with the Chlamydia trachomatis. In fact, we have the co-infection of these two kind of bacteria in from 10 to 40% of the patients. So that is something that we need to know, because it will of course involve the treatment. So we will treat every patient with one of these two diseases with both gonorrhea and chlamydia treatments. Then we have the herpes simplex virus 1 and 2. This is the most common cause of genital ulcers or ulcerations in many countries, with syphilis and the other we saw before. For the genital ulcerations, we can say that the HSV2 infection is the most common etiology. That is higher in females, as we saw with the gonorrhea and chlamydia. That because that has a sort of anatomical reasons. So females have a greater biological susceptibility. So it's more frequent for them to have an HSV2 infection. HSV1 nowadays, of course, is becoming an important cause of genital ulcerations too. That's because it can be transmitted to the genital area through oral sex intercourses, and so is increasingly noted as a new cause of genital infection. Talking about HSV, we have to know that we may worry about the epidemiological synergy with HIV infection and transmission. So the patients with HSV needs to be tested for the HIV infection, because most of them will probably test positive, because it's very frequent the co-infection, and most of all because an HSV 1 or 2 lesion in the genital area, it's a risk factor for an increased risk for the acquisition of the HIV infection, because it creates a sort of open door for the virus to enter the organism. And then we have the syphilis, which is a bacterial sexually transmitted infection. The pathogen involved is the Treponema pallidum. The global prevalence among females and males is the same, it's equal, it's 0.5%. And syphilis too has a very frequent association with HIV infection. Syphilis is an important problem nowadays because, first of all, because of the clinical picture that it gives to the patients that can remain asymptomatic for a long period, maybe also 30 years. So it will, of course, it will help the spreading of the Treponema pallidum infection in all of the partners that the patient has, and most of all because the syphilis has important complications on the CNS and on the cardiovascular system that are characterized by a higher mortality rate. So let's talk about the urethritis. The urethritis are the inflammation of the urethra from either infectious or non-infectious conditions. Of course, when we talk about the sexually transmitted diseases, we talk about infectious conditions caused by pathogens. We have symptoms in a very variable percentage of patients. It depends on what the pathogen involved is. We will see later that Neisseria gonorrhea and Chlamydia trachomatis have different rates of symptoms in the patients. When present, the symptoms are dysuria, pruritus, and the presence of urethral discharge, which can be mucoid, mucopurulent, purulent, or also clear. So the urethral discharge is the most frequent clinical presentation of the urethritis. Other primary localizations of the pathogens involved are related to proctitis and pharyngitis for the reasons we saw before. So for the sexual intercourses that are not protected by the use of a condom. And the diseases are linked to regional complications such as prostatitis and orchitis, and other complications which are general and systemic. So we have septicemia and arthritis. When we talk about the urethritis, we have to distinguish a gonococcal infection and a non-gonococcal infection. That because it changes completely the way the patient presents his symptoms and the treatment itself. So for the gonococcal urethritis, we have the presence of gram-negative intracellular diplococci that can be found on urethral smear, which is the most common way to diagnose the gonococcal urethritis. On a clinical point of view, we have a short period of incubation, less than 7 days, more frequently. It presents with pain, a sense of burning and discomfort in the act of urinating, which is the definition of dysuria. We have a urethral discharge that, in case of gonorrhea infection, is a white discharge, a purulent discharge. The patient has no fever, and it's asymptomatic in less than 10% of the patients. So it's more frequently symptomatic. As we saw before, the gonococcal urethritis are very frequently associated with a Chlamydia trachomatis infection, and so we have the co-infection between these two kind of bacteria. Then we have the non-gonococcal urethritis, so an inflammation or the presence of urethral secretions in which the clinician will not be able to find the gram-negative intracellular diplococci. The pathogens involved in the non-gonococcal urethritis are Chlamydia trachomatis, which is the most frequent. Then we have Mycoplasma genitalium, Trichomonas vaginalis, and Ureaplasma urealyticum. On a clinical point of view, the patient presents with dysuria, so pain, discomfort, or a sense of burning in the act of urinating. Urethral discharge that, in this case, it's not purulent, but it's clear. And in this case too, we don't have any fever, and it's asymptomatic in about 50% of the cases. So it's more frequently asymptomatic than the gonococcal infection that we saw before. How we diagnose urethritis? The diagnosis is based on the direct examination of the discharge. So we have to use a urethral swab and to collect some specimens in which we can evidence the gram-negative intracellular diplococci. So we have to use the gram stain test. in case we have the presence of these gram-negatives in the urethral swabs, of course, we will talk about the gonococcal urethritis. But if we don't find them, we can talk about non-gonococcal urethritis, and then we have to search for the pathogen involved, which more frequently, as I said before, is the Chlamydia trachomatis. Another way to diagnose this kind of urethritis is the culture on specific chocolate agar, and of course the molecular exam, so the PCR testing for the pathogens more frequently involved, so Neisseria gonorrhea and Chlamydia trachomatis. This test, molecular test, has to be done on the first voided urine. While if we suspect infectious urethritis and we treat it, such as gonococcal or non-gonococcal urethritis, but the patient continues to have symptoms, or the symptoms are come back after the initiation of the treatment, we need to search for other pathogens involved. First of all, we will search for Mycoplasma genitalium. On the other hand, we have the cervicitis, which are the inflammation of the cervix that we will see as a purulent or mucopurulent endocervical exudate that will be visible in the endocervical canal or on an endocervical swab. Maybe we will suspect for cervicitis if in the act of doing an endocervical swab, we will see an endocervical bleeding easily induced by the passage of the swab. Symptoms of the cervicitis are vaginal discharge and intermenstrual bleeding, such as, for example, after sexual intercourses. But of course, cervicitis too can be asymptomatic at all. The pathogens involved are the same as that we saw before, so Neisseria gonorrhea, Chlamydia trachomatis, and Trichomonas vaginalis. The differences are in the clinical presentation. So each of them causes pain, vaginal discharge, and intermenstrual bleeding that we see before. But in the case of Trichomonas vaginalis infection, we have a different kind of discharge, which has a totally different color and presentation. It's more thin, and it tends to be greenish or yellowish. And then the difference is between the rates of asymptomatic patients. So in Neisseria gonorrhea, we have the 60% of asymptomatic cases. In Trichomonas vaginalis, 70%. And in Chlamydia trachomatis, we arrive to 90% of asymptomatic patients with this kind of infection. So of course, it's an important problem if we think about the spreading of the infection with sexual intercourses. How we diagnose a cervicitis? We need to do a direct examination of the discharge. If present a vaginal discharge, or maybe a cervical swab, if the discharge is more steeper, to analyze and see if GNID, so gram-negative intracellular diplococci, are present. Then we will do the culture on the chocolate agar, which is the same way to diagnose the urethritis that we saw before. Then we will do some molecular testings, so the PCR testing for the more frequent pathogens involved. In this case, the specimen is the first voided urine too, but we can use the discharge or the material that came from the cervical or the vaginal swab. Talking about cervicitis, we need to know that leukorrhea, which is the observation of more than 10 white blood cells per high power field on the microscopic examination of the vaginal fluid might be a very sensitive indicator of an inflammation of the cervix, and it has a very high negative predictive value. So if we are not able to see the leukorrhea on the microscopic examination of the vaginal fluid, we can exclude the diagnosis of infectious cervicitis because it has a very high negative predictive value. So let's talk about the treatments. For Neisseria gonorrhea, we need to keep in mind the problem of the antibiotic resistance that is spreading in the last years. So when we have to choose for an antibiotic therapy for an Neisseria gonorrhea infection, we need to focus on the local resistance data to the drugs that are more frequently used for this kind of infection. In settings, in geographical settings where local resistance data are not available, the WHO guidelines suggests to use the dual therapy, so the use of two different drugs together over the single therapy in order to avoid the unsuccessful treatment. So the single therapy regimens use ceftriaxone intramuscular as a single dose, or cefixime orally as a single dose. So we have just one dose of drug in order to eliminate the infection. While the dual therapy regimens add the azithromycin to the single therapy regimens that we saw. 1 gram of azithromycin orally as a single dose in order to avoid the antimicrobial resistance and to avoid unsuccessful treatments. While for the Chlamydia trachomatis, we use the doxycycline orally, so 100 milligrams orally, twice a day, and the treatment lasts for 7 days. Or in patients that are not able to take the doxycycline, we can use azithromycin, 1 gram orally as a single dose. But the first line regimen is the doxycycline. So we will do a combination therapy in the cases when we are not sure of what kind of pathogen is involved in the clinical presentation. Then we need to evaluate the appropriateness of the antibiotic treatment. So we need to evaluate the response to the treatment, and the evaluation of the response is a clinical evaluation. So we need to see if the symptoms are still present even after the initiation of the therapy. Of course, in a patient that presents to us with a gonococcal or chlamydial infection, we need to evaluate for other sexually transmitted infections. First of all, HIV infection. So in all the patients we will see today that present to us with a sexually transmitted infection, we need to determine the HIV serological status, because a diagnosis of one sexual transmitted infection is a risk factor for the acquisition of an HIV infection. Of course, it's important to begin some educational plans about STIs and how to avoid them. So the concept of safe sexual intercourses and the use of protective tools. And then we need to think of all the sexual partners that our patient has had in the last 3 months before the diagnosis, in order to test them and treat the ones that will come back positive. Well, in pregnancy, both gonorrhea and chlamydia are an important problem, an important cause of morbidity and mortality. In particular, the Neisseria gonorrhea infection is linked to an increased prematurity of the fetuses, a mother-to-child transmission of almost 40%, And the clinical presentation in the fetus of gonorrhea congenital infection is the conjunctivitis, which is the presence of purulent discharge caused by the keratitis. It can also cause disseminated infection, even in the fetuses. While Chlamydia trachomatis is a very important cause of ectopic pregnancies and infertility connected to the ectopic pregnancies. You have to think about the fact that almost 1/3 of ectopic pregnancies can be related to a Chlamydia trachomatis infection that has not been diagnosed. It has a more important percentage of transmission from mother to child. In this case, it's 70%. And the presentation is similar to the one of neisseria gonorrhea. We have conjunctivitis, and it can cause a delayed interstitial pneumonia, which is a clinical presentation typical of the congenital Chlamydia trachomatis infection, which will present in newborns of 4 to 12 weeks in 20% of the cases of newborns with Chlamydia trachomatis congenital infection. We talked about the systemic and generic manifestations of these two infections. So about the gonorrhea, we need to talk about the possibility of the presentation as a septicemia. So the presence of the bacterial infection on the blood cultures. It presents with fever. It can present with mono or oligoarthritis, so pain of the articulations. On the skin, we will have pustular lesions, which are characteristics as we see in this picture, and it regards less than 3% of the gonorrhea cases and diagnoses with the urethral discharge. While the reactive arthritis is a generical and systemic complication of both neisseria gonorrhea and Chlamydia trachomatis. It affects mostly men, so we have male patients that have urethritis, of course. They may have conjunctivitis and clinical presentation as a migratory oligoarthritis. Usually it involves less than 5 spots, and usually the more frequent are the knees and the sacroiliac joints. It can present as a sort of rheumatological condition, but classically and traditionally the rheumatoid factor is come back negative from the laboratory tests, and we need to search for neisseria gonorrhea, Chlamydia trachomatis, but also Salmonella, Shigella, and Campylobacter jejuni. Okay, then we have the other type of presentation of the sexually transmitted infections. That is the presentation as genital ulcerations. The most frequent pathogens involved are the Treponema pallidum, so the syphilis, the herpes 1 and 2, Klebsiella granulomatis, and Haemophilus ducreyi. Okay, let's talk about the syphilis. The syphilis is a bacterial sexually transmitted infection caused by the Treponema pallidum. The incidence is of 5.6 million new cases in 2020, so the last year, among adolescents and adults from the age of 15 to the age of 50 years old. The global prevalence is of 0.5% among males and 0.5% among females of that age group, so 15 to 49. The highest rate of incidence has been seen in the WHO African region, And the transmission routes are, of course, the sexual contacts that has to happen between infectious lesions of the mucous membranes or the damaged skin. So we need to have a sort of point of entry of the entry and exit of the pathogen. Very rare nowadays is the transmission by blood transfusions, or it has a vertical transmission, so from mother to child, from a pregnant woman to her fetus. The clinical presentation divides the syphilis into two big phases, which is the early syphilis and the late syphilis. In the early syphilis, we need to make a differentiation between primary stage, secondary stage, which happens after 4 to 10 weeks, and the early latent stage, which is the a diagnosis, an infection of syphilis in less than 2 years. It's written 1, but it's 2 years. Then we have the late syphilis, that we can divide into late latent stage and tertiary stage. The late latent stage occurs when the infection is older than 2 years, and then we have the tertiary stage, which can occur from 1 year after the acquisition of the infection to almost 30 years after the infection itself. And in 1/3 of the cases, it occurs after 30 years. So the primary stage clinically presents as a solitary and painless ulceration that occurs on the site of the entry of the bacteria into the organism. Usually we talk about the vagina, the penis, or the anus, but of course it may be in areas different than the genital areas. The mean incubation is 21 days, but it goes from 10 to 90 days. So the primary lesions are characteristically painless. They begin as raised papule that will ulcerate in the center before healing within 3 to 10 weeks, even without treatment. So we have this primary ulceration, and even if not treated, it will heal in 3 to 10 weeks. So that's the reason why this ulceration may go unnoticed by patients, because it can be an internal lesion, so the patient doesn't even notice it, and then it goes away in just a few weeks. If not treated, of course, the primary lesion progresses to the secondary stage of the disease, which occurs from 4 to 8 to 10 weeks after the appearance of this primary lesion. The secondary stage of syphilis is characterized as generalized mucocutaneous lesions that will affect both skin and mucous membranes. It occurs after 4 to 8 to 10 weeks after the primary lesion as a cutaneous or mucous rash. The rash, of course, can mimic either infectious or non-infectious conditions. It's often symmetrical, non-itchy, and it affects both palms and soles, so hands and feet. Of course, the presentation that we have on skin may be associated with non-specific constitutional symptoms such as fever, lymphadenopathy, an enlarged liver and spleen, the liver cytolysis, and nephrotic syndrome. So we have very different presentations that affect different organs of the organism almost 2 months after the infection entered the organism. In this case, such as the primary stage, the symptoms will spontaneously resolve with or without treatment. So even if the patient does not receive an appropriate treatment, these cutaneous lesions and of course all the non-specific symptoms, systemic symptoms, will disappear even without treatment. And then the patient enters into the latent stage. The latent stage is a stage characterized by a positive syphilis serology. So the relevation of a syphilis infection in the laboratory tests, but the patient does not present any clinical symptom or sign. So the patient is completely asymptomatic, but he results positive on the laboratory testing for syphilis. The latent phase can be divided into two different groups, which is the early latent syphilis, so an infection that lasts for less than 2 years, and late latent syphilis, so the presence of the infection of the disease for 2 years and of course more. We have different treatments for early and late latent phase. So it's important to check if we can assess whether the patient is in early latent phase or late latent phase. But in case we are not able to detect which phase we are talking about, patients with unknown duration of the diseases may be treated for the late latent syphilis. Sexual transmission of the syphilis typically occurs only during the primary phase and the secondary phase, and also in the early latent phase. So we have primary, secondary, and early latent phase. While mother-to-child transmission, so the vertical transmission, has been documented to happen up to several years even after the infection. So it's a more long possibility of transmission, the vertical one. The tertiary stage may occur after 1 to 30 years after the beginning of the disease, so after the primary lesion. And in 1/3 of the cases, we have the occurring of the tertiary stage after more than 30 years from the primary lesion. Approximately 1 out of 4 patients will develop the late clinical consequences of the tertiary phase, which is an important group, an important rate, 1 out of 4. The main manifestations of the tertiary stage are on the CNS, so we have the neurological disease connected to the syphilis, which is also known as neurosyphilis. It may affect also the cardiovascular system, so the cardiosyphilis, with the appearance of an aortic aneurysm or the aortic valve insufficiency. So it will affect both the vascular system and the heart itself. And then we have the skin cutaneous lesion that are known as gummatous lesions or gumma, which are characteristic of the tertiary stage of the syphilis, which are these destructive cutaneous lesions that we nowadays are not able to see with the frequency we saw them in the last decades. The neurosyphilis is the manifestation of the syphilis disease in the CNS, so the central nervous system. It can occur at any stage of syphilis infection, so in the primary, secondary, latent, and tertiary stage. And it can occur even if the first few months after the infection itself. During the primary or secondary stage, the manifestation on the CNS, it's most frequently asymptomatic, so we have just the localization of the bacteria into the CNS, but it will not show up. But we may have some acute change in the mental status of the patient, manifestations of meningitis, the occurrence of strokes related to the syphilis infection, dysfunctions of the cranial nerves, and abnormalities of the eyes and ears, so auditory and ophthalmic or ocular abnormalities. While if the neurosyphilis occurs in the tertiary stage, we have two different clinical presentations that are the tabes dorsalis, which is the slow degeneration of the dorsal columns of the spinal cord. The dorsal columns are the ones responsible for the proprioception, or the general paresis caused by chronic meningoencephalitis, caused, of course, by the Treponema pallidum, with alterations on the motricity and on the cognitive status. So we have an initiation of dementia related to the presence and the effects of the Treponema pallidum into the CNS. So how we diagnose the syphilis infection? We have two different possibilities: direct examination or serology testing. The direct examination, of course, require exudates coming from primary, secondary, or early congenital syphilis. The specimens that we catch may go under the dark field microscopy that can demonstrate the presence of the treponemes, which are these bacteria characterized by specific motility and morphology. And that is the most specific way to diagnose a syphilis infection on the early stages. But it's usually limited to some specialized laboratories. It's a highly specific method of diagnosis, and the sensibility is about 50%. So, of course, if the sensibility is not so high, a negative result of the dark field microscopy does not exclude at all a diagnosis of syphilis. Then we have the direct fluorescent antibody test and the molecular exam to directly detect the genome of the Treponema pallidum by using a PCR test from specimens that can come by any lesion, exudate, any tissue or any body parts affected by the primary lesion or the secondary stage manifestations. Then we have the serology, which is the screening test more frequently used. We have two different types of serological tests: the non-treponemal or the treponemal test. To have a presumptive syphilis diagnosis, so we're not certain about it, but it's just a presumption, we require positive results from at least one of treponemal or non-treponemal, while a confirmed diagnosis requires positive results from both types of serological tests. We were talking about the serological diagnosis of syphilis. So we have the non-treponemal tests. The non-treponemal tests are these two that you see in these two boxes. So the VDRL, the Venereal Diseases Research Laboratory, and the RPR, which is the Rapid Plasma Regime. These tests are meant to detect the antibodies IgM or IgG antilipid of the syphilis. But these two antibodies are also produced by other pathogens in other type of diseases. So the non-treponemal tests are not so highly specific. So we may have lots of false positive results in conditions such as patients presenting with fever, acute viral infections, or maybe just patients that are characterized by a diagnosis of chronic autoimmune diseases. So in this type of patients, we may have false positive results from non-treponemal tests. Non-treponemal tests may also be negative for up to 4 weeks after the primary lesion first appears. So we need to wait until 4 weeks after the appearance of these lesions on the organism, and they may be negative also in late latent syphilis. So they may be negative in the very early stages, but also in the very late stages of the diseases. While the treponema tests are these three: the TPHA, TPPA, and the research of fluorescent treponemal antibodies. These tests are meant to detect the antibodies against antigens that are specific, produced by the bacteria responsible for the syphilis. So the use of one of these tests, so one treponemal test, is used as a confirmatory test after a patient presents with a positive non-treponemal test. So the first line may be a non-treponemal test, but after a positive non-treponemal test, we need to run a specific treponemal test in order to confirm our diagnosis. The treponemal tests usually remain positive for the entire patient's lifetime, even after the initiation and the success of a specific treatment. So it's like a scar of the infection that the organism has. And of course, that means that a positive treponemal test does not distinguish between an acute, so active infection, and an infection that has occurred in the past years of the life of the patient and has been previously treated. So here is a timeline of the laboratory presentation of the syphilis. So we see that in the very early phase, we may not be able to see any kind of laboratory finding. The first one that comes back positive is the IgM. And while the treponemal tests, so the TPHA and the research for the antibodies, the fluorescent antibodies, will come back positive after 2 to 4 weeks from the primary infection, and then they will stay positive for the entire lifetime of the patient. While the IgM during the years post-infection, of course, will decade their levels in blood. The non-treponemal tests, so the BDRL and the RPR, will come back in 2 different ways if the syphilis has been treated or not treated. So in an untreated condition of syphilis, of course, we will have the positivity of the non-treponemal tests. And the positivity, of course, of the treponemal tests. While in a treated syphilis, so in a syphilis that has completed his treatment, we will have a positive treponemal test and levels of positivity of the non-treponemal tests that will be less high years after year. So we will do a sort of follow-up of the serological status of the patient after the treatment of the syphilis, and we will see the level of BDRL and RPR that will decrease after the resolution of the infection with the antibiotic treatments. How do we treat a patient with syphilis? Of course, we saw that the treatment is different based on the clinical stage and the clinical presentation of the patient. So in the early syphilis, so an infection that is present less than 2 years, we use the benzathine penicillin G, 2.4 million units intramuscular as a single dose. While in the late syphilis, so an infection that has occurred more than 2 years ago, the injections are intramuscular, but once weekly, and they have to be repeated for 3 weeks. So the treatment is a little bit longer than the early syphilis. And then we have the neurosyphilis that, of course, is a more complicated presentation, a more characterized by a higher rate of mortality. And so the treatment is not intramuscular, but is intravenous, and it will last for about 15 days. The clinical evaluation to the response of the treatment, of course, will detect if the symptoms are still present or not after the initiation of the treatment. Then we will have a follow-up, so a biological evaluation using laboratory tests after the resolution of the infection using the antibiotic treatment. So we will see the patient after 3, 6, and 12 months in order to evaluate the levels of the non-treponemal tests, as I saw before. So the TPHA, which is a treponemal test, will remain stable because we said that it will stay stable and positive for the entire lifetime of the patient, while the non-treponemal tests will decrease their level of positivity during the follow-up. So every 3 months, we will be able to see a decreased level of positivity of BDRL. Of course, what we saw before with the other sexually infections, it's correct for syphilis too. So we need to evaluate and test the patient for other STIs, first of all for HIV infection, and we need to educate the patient about the concept of a sexually transmitted infection, and so how to prevent them. So the use of the protective tools and the concept of protected sex. In this case, we need to do the evaluation of all the sex partners too within the last 3 months of the sexual activity of the patient with the syphilis diagnosis. Congenital syphilis, so the transmission of the syphilis infection from mother to child in uterus, is a disease that is characterized by a very high rate of mortality and morbidity. It's usually devastating for the fetus in case where the mother is infected and is not aware of the infection, so it's not nor diagnosed or treated. In 2020, we had an estimated 350,000 adverse pregnancy outcomes worldwide related to a syphilis infection that was not being diagnosed. Of course, the syphilis infection has a epidemiological link with the HIV infection. So mothers, pregnant women with a syphilis infection need to be tested and followed for the HIV serological status. So we need to check the serological status of these patients, because the syphilis diagnosis is, of course, a risk factor for the acquisition of the HIV infection. And the congenital syphilis, or just the diagnosis of syphilis in a pregnant woman, is responsible for fetal loss in 40% of the pregnancies, perinatal mortality in about the 20% of the fetuses of the newborns, and long-term sequelae, so complications that will happen after a few years in 20% of the newborns that will stay alive after the first year of life. What about the treatment of syphilis during pregnancy? Of course, the WHO guidelines recommend syphilis screening for all the pregnant women during the first visit. So at the moment a woman discovers his pregnancy, she needs to do a first evaluation visit, and in that scenario she has to do, of course, all the tests for the sexually transmitted infections related to a high morbidity and mortality related to pregnancy, and of course for syphilis too. So in pregnant women with early syphilis, the WHO recommends the same treatment that we saw for the adults and adolescents with early syphilis. And in pregnant women with late syphilis, so an infection that lasts for more than 2 years, or just pregnant women with an unknown state of syphilis, so a pregnant woman who presents with a diagnosis of syphilis for the first time and that we are not able to understand in which clinical phase it's located, she needs to be treated such as a pregnant woman with late syphilis. So the penicillin for 3 consecutive weeks, once a week. The last topic is the herpes, so the genital herpes simplex virus. We have 2 different pathogens involved in this kind of disease, the HSV2 and the HSV1. The HSV2 is the most common cause of genital ulcerations in many countries, and of course is a lifelong infection. So once you catch the infection of HSV 1 or 2, it's the same. You will take the patient will take the virus for the entire lifetime. We have an estimated almost 20 million new HSV2 infections in 2020 among adults and adolescents from the age of 15 to the age of 49 years old. The highest rate is among younger age groups, so 15 to 24. In 2020, we had an estimated 417 million people diagnosed with an HSV2 infection, for a global prevalence estimated in 11.3%. In this case, the highest prevalence is in the WHO African region, like the syphilis did. And infections rate is consistently higher in females rather than males for biological reasons, because women are more exposed to the transmission of this virus, and of course of the HSV1 too. HSV1 typically causes non-sexually transmitted oral herpes infection, but nowadays with all the new practice, HSV1 can be transmitted, of course, through genitals, and it's becoming an important etiology of genital ulcerations, such as the HSV2. So HSV2 has an important epidemiological correlation to the HIV infection, because it has a synergy with HIV infection and transmission. So people who are infected with HSV2 are approximately 3 times more likely to become infected with HIV infection than the patients that are not infected with HSV2. And people with the co-infection, HIV and HSV2, are, on the other hand, more likely to transmit HIV to others, because, of course, people with the co-infection has the HIV infection and the genital ulcerations that are an entry and an exit door for the virus to spread in the sexual partners. Then we have to say that a person who is HIV positive and has an HSV2 infection is often more symptomatic and is has a more severe presentation of the genital herpes. It can lead to serious complications, such as the migration to the CNS, or maybe just the eye infection by the HSV2, or the lung infection, so a viral pneumonia. For the clinical presentation, the genital herpes is a lifelong symptomatic condition that can be characterized by frequent or less frequent symptomatic recurrences. So it depends from the patient itself. At the beginning, mostly of the cases are asymptomatic. That means that the majority of the people that have the HSV2 infection have not been diagnosed yet because they don't have any symptom. The first episodes of symptoms of the primary genital HSV infection occurs with bilateral clusters, so groups of erythematous papules, maybe more vesicles, and ulceration on the external side of the genitalia or in the perianal region. So we have these groups of vesicles occurring 4 to 7 days after the exposition to the HSV, so the sexual intercourse. These vesicles are painful, itchy, and they may cause dysuria in almost 80% of the patients with HSV2 disease. And we have also systemic symptoms such as fever, lymphadenopathy, headaches, and pain, muscular pain. So it's an acute viral infection. For the diagnosis, the genital herpes infection is often diagnosed just looking at the clinical presentation, because laboratory testing, so the serological profile of the patient may not be linked to the phase in which the patient is. Of course, the serology for the HSV will come back positive in a very high percentage of persons, even if they are not in an acute phase, because the HSV has spread all over the world in a very important way. So the laboratory testing is more useful to distinguish between the HSV1 and the HSV2 disease. The laboratory testing includes the direct detection of the virus from the lesions or the indirect serological methods. Of course, we can search for the specific antibodies of HSV2 or HSV1, which develop in the first weeks after the initiation of the infection, and they will stay positive for the entire lifetime of the patient. The viral culture has previously been considered the gold standard for the HSV2 diagnosis, but nowadays the molecular testing are preferred due to a higher sensitivity, the facility of the collection of the specimens, and of course the faster results. Considering also that the viral culture is a very difficult execution in a laboratory. So the treatment is different for the first clinical episode and the recurrences of the genital herpes. For adults and adolescents with a first clinical episode, yeah, that's HIV infection, but it's not HIV infection, HSV infection. So for adults and adolescents with a first clinical presentation of the genital herpes infection, the WHO guidelines recommend, of course, the treatment over the no treatment. These recommendations, so to treat the first presentation of an HSV infection, also applies to people living with HIV. The preferred regimen is using the acyclovir 400 milligrams orally 3 times a day for 10 days. Then we may use 200 milligrams orally for 5 times a day for 10 days. or change the drug using the valacyclovir or famciclovir. While the recurrent clinical episode of genital HSV infection, of course, we prefer to treat them over no treatment. The WHO says that we need to treat the first episode, but also the recurrent clinical episode and presentations. In case of recurrent episodes, we need to start the treatment within the first 24 hours of the from the beginning of the symptoms of the pain, the itchiness, and all the stuff. Or maybe better during the prodromal phase. So the patient will know if they are having a recurrence of the HSV infection, because they will notice a sort of discomfort and sense of pain and itchiness, and it's better to start the treatment during these very early stages, because it's linked to a better outcome in terms of control of the symptoms. Because of course we are not able to cure this infection, but we can treat the symptoms and in order to achieve the complications, the local and the systemic complication. These recommendations also applies to people living with HIV and people who are immunocompromised, but also pregnant women. So the guidelines for adults, adolescents, and pregnant women recommend the use of aciclovir 400 milligrams 3 times a day orally for 5 days, or 800 milligrams daily for 5 days, or 800 milligrams 3 times a day for just 2 days. While the guidelines for immunocompromised patients and people living with HIV, so secondary immunocompromisation, recommend the use of acyclovir 400 milligrams orally 3 times a day for 5 days. And then we can use valacyclovir and famciclovir. Then we have the treatment for severe recurrences episodes. So the recurrences of the genital ulcerations related to the HSV infection that are very frequent, severe, and can cause, of course, distress and lower the quality of life of the patient itself. The WHO suggests the use of the suppressive therapy that has been seen to be better in terms of control of the symptoms and frequency of the recurrences over the episodic therapy. So in patients that have recurrences, very frequent recurrences, severe and distressful, so that tell us that they have a decreasing of their quality of life related to this infection and to the symptoms that this infection has, we need to recommend the suppressive therapy for 1 year, and then reassess the patients after 1 year to see if the symptoms are still present, if the disease is controlled by the therapy, and if we can switch to the episodic therapy, or we need to continue the suppressive therapy. That has been seen to not be linked to any viral resistance complication. So the regimens used for adults, adolescents, and pregnant women are the acyclovir 400 milligrams orally twice daily, every day, which are the same for the immunocompromised patients and for the people living with the HIV infection. So the most important thing to talk about when we discuss about sexually transmitted diseases and infection, of course, is the primary prevention. So focus on the education of people at risk for sexually transmitted infection in order to decrease the incidence of these diseases and to have a better control of the spreading of the infections. So the first thing we need to do is understand and let the patient understand the concept of sexually transmitted infection and the methods that they can use to the primary prevention. So we need to focus on working, speaking, and explaining to people who are most affected or vulnerable to sexually transmitted infections. So, for example, sex workers. And in particular, we need to focus on the adolescents that are the most interested age group in the incidence of the sexually transmitted infections. So it's important to ensure the an easy access to the vital informations, all the preventive tools such as condoms and services such as vaccinations against HPV, or HIV, the voluntary medical male circumcision that has been seen to be related to a less frequent incidence of sexually transmitted infections, the screening testing, and the possibility for every patient that has a sexually transmitted infection to have access to treatment and to medical care. Important is the promotion of the consistent use of the preventive tools, so the male and female condoms, the increase of the importance of the awareness of a sexually transmitted infection, because we see almost daily patients that don't want to be tested for a sexually transmitted infection, mostly for the stigma that sexually transmitted infection diagnosis can have on the quality of life of the patient, but also for the fear of the diagnosis itself or of the treatment. So we need to explain to every patient that the testing is just the instrument that we need to use in order to give them a better health status and to avoid the development of the complications related to a possible diagnosis of sexually transmitted infection. And then at the end, we need to increase the awareness of women independence and the importance that women have in the process of decision making, even regarding the sexual intercourses and the sexual life of the couple.